أهلا وسهلا فيكم بسامس قسم الصيدلي. اليوم المحاضرة هي جزء من عدد كبير من المحاضرات لقسم العناية المشددة. اليوم اللكشر هي Management of Oncologic Emergencies. والمحاضر معنا الدكتور همام الخالد. دكتور همام هو فارماسي كلينيكال سبيشالست بميدستار جورجتاون يونيفرسيتي هوسبيتال in واشنطن دي سي بأمريكا. وكمان بحب أقول إنه بالشات أنا حطيت اللينك للسلايدز so you can download the slides. وكمان في link to the lecture recordings to all the ICU course. يعني باللينك في recordings ليوتيوب وفي بيضمن كل المحاضرات اللي عملناهن بالماضي. يعني فيكم تشوفوهن. So دكتور همام المحاضرة حتكون بالإنجليزي، معظم المصطلحات هي بالإنجليزي. الدكتور همام تفضل.
شكرا لما مرحبا بالكل. أنا اسمي همام الخالد، ومثل ما قالت لما أنا بجورجتاون يونيفرسيتي هوسبيتال بدي سي. My main focus is on acute leukemias و blood cancers أو سرطانات الدم. بس اليوم هنحكي على management of oncologic emergencies across the board of solid tumors and malignant hematology. And my goal is practical and evidence-based. By the end, you should be able to recognize these emergencies, assess risk quickly, and know exactly what to order and when. These are some of the abbreviations that I will be using across the presentation. These are for your reference. And I have no financial affiliation or conflict of interests to report. Just a quick overview. I want to orient you to where we are in the bigger picture of oncologic emergencies. These are grouped into three categories. There's metabolic, hematologic, and structural. Metabolic, these are the tumor-like syndrome, hypercalcemia, SIADH, and lactic acidosis. Hematologic emergencies are febrile neutropenia, hyperleukocytosis, hyperviscosity, DIC, or disseminated intravascular coagulopathy, especially in acute promyelocytic leukemia, but that's not something we will talk about today. And there's structural, superior vena cava syndrome, spinal cord compression, tamponade, and bowel obstruction. Mostly for the structural oncologic emergencies, these are managed with surgeries and or steroids, but we will not talk about them today. Today, we'll focus on four main oncologic emergencies, two metabolic and two hematological emergencies. And most of you will encounter on any inpatient oncology service, and pharmacists' knowledge make a big impact in knowing these emergencies. By the end of this presentation, you will be able to define each condition, apply the right diagnostic criteria, assess patient risk, and outline the full management, including the most important clinical pearls. Start with febrile neutropenia. This is the most common oncologic emergency, and it comes with one rule that cannot be broken, which basically antibiotics within 60 minutes of presentation. Once we delay more than that, you are increasing the risk of mortality. The definition of febrile neutropenia, it actually requires two things together, fever and neutropenia. And we define fever by a single oral temperature of at least 38.3 Celsius, or a temperature that stays at 38 Celsius or higher for at least 1 hour, or what we call a sustained fever. And neutropenia alongside the fever. And this is defined by ANC below 500 or ANC below 1,000 that's expected to fall below 500 within the next 48 hours. That second part is important. A patient whose count is trending down fast is treated as neutropenic even before they cross that threshold. And these are the patients that you see mainly in acute leukemias, sometimes in lymphomas. Why does it matter to move quickly on febrile neutropenia? Because overall mortality is actually about 11%, and it increases to about 50% if there is a septic shock. Bacteremia is found in about 10 to 25% of patients at the time they come in, which means not all febrile neutropenia are infections. Your highest risk group are patients after inductions for acute leukemias, anyone with expectant neutropenia lasted more than 7 days, and patients who are on high dose conditioning regimens, and these are for bone marrow transplants or other cellular therapies. Initial evaluation for febrile neutropenia, first, we do need to assume that it is infection until proven otherwise. The key point is do not wait for the test results before starting antibiotics. Antibiotics must be started at the time of presentation. That's the biggest thing. And after we start antibiotics or during starting antibiotics, we want to obtain the history of the patient. So ask about the chemotherapy regimen and when the lowest blood count or the nadir is expected or they are during the nadir point. Have they received fluoroquinolone and antibiotics as a prophylaxis, like levofloxacin or ciprofloxacin? Because that actually changes your oral treatment options later. Any recent hospital stays, prior colonization with drug-resistant bacteria, and whether they have essential line or not. The physical exam is focused on the mouth for sores or thrush, and this is what we want to assess if there's mucositis or severe mucositis. Any areas around the perianal area, and note that if there's any perianal involvement, we do not want to do any rectal exam or digital rectal exam in neutropenic patients because that increases the risk of infection. We want to check the skin, catheterocytes, lungs, sinuses, if there are any concerns for infections there. And in terms of the investigation, are obtained alongside antibiotic initiation, and this is where we get the blood counts, CBC, CMP, lactate. We want to get blood cultures. We'll talk about that in a second. Any urine cultures, chest X-ray, not always diagnostic, but CT can be diagnostic. Respiratory vital panel, especially with all the upper respiratory viral infections that are going on, and side-directed cultures, as indicated if there's like a skin infection and so forth. We also want to tailor the workup to the local anti-biograms, like if there's prior MDRO history and the severity of the presentation. When we have patients with febrile neutropenia, we want to risk stratify them. So risk assessment determines the entire plan for these patients if they're being treated inpatient or outpatient. And the tool we use is something that's called the MASC score, or Multinational Association for Support Care in Cancers. Let's walk through the scoring. At time of presentation, do they have mild or no illness? And that gives them 5 points. No low blood pressure, that gives them 5 points. No COPD, that gives them 4 points. Do they have solid tumor or no prior fungal infection, that gives them 4 points. No dehydration, 3 points. Was an outpatient when fever started, that gives them 3 points. Age under 60, that gives them 2 points. And the maximum score is a total of 26. The higher the number, the lower the risk. So low-risk patients are defined when they have a mass score of over or equal to 21. And these are the patients who are usually solid tumor, short expected neutropenia, fever started as outpatient. These patients may be a candidate for oral outpatient antibiotics, ciprofloxacin plus amoxi or augmentin. That's a category 1 for the NCCN guideline, or moxifloxacin alone as an option. If their mass score is less than 21, this is considered as high risk. And these includes patients who are ANC below like 100, and this is what we call profound neutropenia or expected neutropenia in the 7 days. And these are patients who have like blood cancers, acute leukemias, lymphomas, sometimes myelomas. Do they have a history of bone marrow transplant? Did the fever start in the hospital? So these patients, they need IV antibiotics, no oral options for them. So they need to be treated in the hospital. One big point is if patients are receiving fluoroquinolones in the past, regardless of their low risk or high risk, you really can't use fluoroquinolones to treat, because if they are infected, they have developed a resistance to the fluoroquinolone that they're on. How do we treat these patients? So for high-risk patients, the rule is very simple. We do want to start anti-pseudomonal antibiotic within 60 minutes of triage. These are the options that we have, piptazo or Zosyn, 4.5 grams IV every 6 hours, and that's a category 1 recommendation. We have cefepime 2 gram IV every 8 hours. That's another category 1 recommendation. Meropenem or ipimenem also are category 1, but we usually reserve them for patients who have prior ESBLs or they continue to be febrile on Zosyn or cefepime for 2 or 3 days. Tazidime has category 2B recommendation just because it has weak activity against gram-positive bacteria. So we want to avoid it in patients who have gram-positive sources is suspected, like skin infections or line infections. All of these doses assume normal renal functions, and we want to adjust based on the creatinine clearance of the patient. Not all patients need vancomycin presentation, and this is a strong recommendation. We only add vancomycin in certain situations. And these are if the patient have any central line infections, do they have skin and soft tissue infection, hemodynamic instability, so if they're like sepsis or in septic shock, or if they have a MRSA risk, if they're like in the hospital for too long, or they have prior MRSA infection, or if they have severe mucositis or mouth sores. Otherwise, your patients do not need vancomycin, and multiple studies have showed empiric vancomycin plus anti-pseudomonal coverage is not any better from anti-pseudomonal coverage if they do not have these criteria. In 4 to 7 days after starting cefepime or cefepime plus vanc or Zosyn, if the patient is still febrile, that's when we want to start broadening the antimicrobial coverage. And that's when we start thinking about meropenem or ipimenem, and we want to add antifungal coverage. And we usually use an echinocandin like micafungin or voriconazole, especially in patients who are at risk for aspergillus. Some of the clinical reports to take away from febrile neutropenia is that ceftazidime has weak gram-positive activity, so do not use if you suspect gram-positive sources. Always match empiric antibiotic to your local resistant data and the patient's prior colonization history, if it's available. Filgrastim, or what we call GCSF, is not routinely given for established febrile neutropenia. There is some data for patients who have prolonged neutropenia with active infection or life-threatening infections. Then we do want to give GCSF. Again, it really depends on the patient that you're trying to treat. If your patient has severe beta-lactam allergy, you want to consider vancomycin plus aztreonam. Always involve infection, disease, and allergy services to assess the patient if available. The old approach was to continue antibiotic until ANC is over 500 for 2 days, and the patient has been afebrile or fever-free for 48 hours. But new evidence support stopping earlier, and we will talk about that in the next slide. Step up to echinocandins like mycophengens or sometimes azoles if fever lasts beyond 4 to 7 days on broad spectrum antibiotics. Never use oral antibiotic if the patient was taking fluoroquinolone as prevention, and that applies to both low risk and high risk patients. Now, how do we think about de-escalation of antibiotics? Again, the old rule was to continue antibiotics until ANC recovered over 500. And this is sometimes not feasible in certain patients, especially the acute leukemia patients. Your acute myeloid leukemia, sometimes they're neutropenic for months, or myelodysplastic syndrome patients who are at high risk, they're neutropenic, like chronically neutropenic. So it's not feasible to continue IV antibiotics for a month or two when they are stable. So according to the European Conference on Infectious Disease and Leukemia in 2013, and it was updated in 2015, antibiotics can be stopped in stable fever-free patients regardless of their white cell count. But there are certain criteria that needs to be met. First, they need to be fever-free for at least 48 hours, with at least 72 hours of antibiotics. Blood cultures and vital signs stable throughout, clinically improving. So no new symptoms or no focus on infection. Blood cultures have been negative and no identified source. And that's when it's safe to de-escalate from IV to oral antibiotics. And there are certain, there are like 3 trials that I want, or 3 papers that I want to highlight. The first one that came out in 2017, that's called the How Long trial, and it focused actually on patients with acute leukemias. It's a randomized controlled trial, and basically it showed that stopping by clinical criteria that we talked about, instead of waiting for ANC recovery, reduced antibiotic use with no worse outcome. So there was no increase in mortality. And there's a meta-analysis in 2025 that was published, found that early de-escalation had odds ratio of 0.2 for mortality, actually associated with better survival, likely because fewer C. diff infections that results from prolonged antibiotic use, fewer drug-resistant organism, and less drug toxicity. One important warning from De Jong et al. That was published in 2022. If the patient still has fever at day 3 or after, stopping carbapenem at a fixed 72-hour cut point, regardless of fever, actually causes harm. So being fever-free is required, a safety criteria. So do not stop antibiotic if your patient is fever. Our case example for febrile neutropenia is that we have a 55-year-old woman with AML. She's day 12 after induction chemotherapy of 7+3. She presents with temperature of 38.9 Celsius, heart rate is 118, blood pressure is 90/58, respiratory rate is 22, ANC is basically 0, and she has a PICC line that has been put in for 10 days. She's sweating and she is confused. So how do we triage this patient? How do we risk stratify them? So this is a patient who is presenting with septic shock, blood pressure, low blood pressure, fast heart rate, there's confusion. The mass score is well below 21 without even calculating it. So she is high risk. So step 1 is actually getting 2 blood cultures, one from a vein or peripheral artery or a vein, and one through the PICC line. Ideally before starting antibiotics, but we do not want to delay antibiotics to collect them. Step 2 is to start anti-pseudomonal coverage, and that's with piptazole or Zosyn 4.5 grams IV or cefepime 2 grams IV within 60 minutes of presentation. This patient, we do want to start with empiric vancomycin because the patient is septic and she has a PICC line as a possible source of infection. Patient is hemodynamically unstable, so we do want to give fluids. 30 mLs per kilogram, that's what's recommended. And we see how they respond to the fluids. If there's no response, then we want to start some pressors to maintain a blood pressure over 65. Blood pressure over 65. If the fever persists after 47 days, this is when we'll start thinking about broadening the antibiotic that we have on this patient. Moving on to tumor lysis syndrome, this is our second oncologic emergency that we see. And it's actually very common, especially in malignant hematology. And TLS is actually way easier to prevent than treat. So recognizing these patients early enough is key in treating or preventing tumor lysis syndrome. Talk a little bit about pathophysiology. TLS happens when cancer cells die rapidly and release large amounts of content into the blood faster than the kidneys can clear them. This causes 4 metabolic problems. We have hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. There are common triggers. It's not comprehensive, but the most common ones are starting chemotherapy, cytotoxic chemotherapy. There's a drug called venetoclax that we use commonly in CML, CLL, AML, and sometimes NDS, and that requires specific dose ramp up. So we start with a low dose and increase the dose over days or weeks, depending on what we're treating, to reduce the risk of TLS. Steroids and lymphoma. We know lymphoma is very sensitive to high dose of steroids. And even without treatment, sometimes they present with spontaneous tumor lysis syndrome. Just because the disease burden is so high, they start to lyse on their own. And these are the patients with high burden, like Burkitt's lymphoma, especially if it's a bulky disease, or acute leukemias. And even before they start treatment, they start to lyse. Here is the cascade of TLS. So basically, the cell lysis releases large amounts of potassium, phosphorus, phosphate, and purines. The purines are the components of the cell DNA. These are broken down by xanthine oxidase into uric acid, and too much uric acid starts to crystallize and block the kidney tubules. Hyperkalemia from the potassium release combined with poor kidney release clearance creates a risk for fatal heart arrhythmia. So these are the patients that you want to put on telemetry. Hyperphosphatemia causes calcium phosphate crystal deposits. And importantly, in the Raspail-Case era, hyperphosphatemia has now replaced uric acid as the main cause of kidney injury. Hypocalcemia, because of the binding of phosphate, can cause muscle cramps, seizures, and QT prolongation. Of course, these are in extreme scenarios, but they can happen. And understanding this chain of reaction is actually what drives every decision in TLS management. How do we diagnose and risk stratify TLS? So we diagnose it based on the Cairo-Bishop criteria. And there are 2 main criteria. There's the lab TLS and there's the clinical TLS. The lab TLS, it has to meet at least 2 of the 4 abnormalities within 48 hours, 3 days before or 7 days after starting treatment. And these are uric acid over 8 or an increase of 25% from baseline, phosphorus is over 4.5, potassium over 6, or collected calcium less than 7. Clinical TLS, that's when we have lab TLS plus acute kidney injury, arrhythmias, seizures, or death. And death has been reported because of TLS if it's not managed appropriately. The risk stratification, so it really depends on the type of treatment that you're using and depends on what type of cancer you have. So the high-risk patients, these are patients with Burkitt's lymphoma, especially bulky disease, acute leukemias, like acute lymphoblastic leukemia with a white blood cell count over 100,000, or acute myeloid leukemia with white blood cell count over 50,000. You have a high LDH. We have the neoclac start, and or pre-existing kidney problems. Your intermediate risk patients, these are most of the lymphomas like DLBCL with high LDH, or patients who are starting cellular therapies, things that we call bispecific antibodies or CAR-Ts. Your low-risk patients, most of the solid tumors, or slow-growing lymphomas, are what we call like indolent lymphomas with small tumor burden. So risk level directly determines whether we use allopurinol or rasburicase, which we'll talk about. TLS management have 5 steps that build on each others. First, you want to risk assess before chemotherapy starts. So you want to evaluate tumor size, LDH, white blood cell count, and baseline kidney function to determine like if the patients are high risk or low risk. Step 2 is hydration. It's the most important step in preventing and treating TLS. And that prevents the buildup of electrolytes and uric acid in the kidneys. And that's why we want to start saline at 150, 200 mLs per hour. Sorry, there's a typo there. And that's the standard maintenance. And the main point is that we want to target a urine output of 2 mLs per kilogram per hour. And we don't want to use potassium in the IV fluids, and these are your lactate ringer, because they have 4 milliequivalents of potassium in each liter that you're giving these patients. And at that rate, you're given a good 4 to 5 liters of these patients, which can accumulate to 20, 24 milliequivalents of potassium a day. Urate lowering therapy, and this is like your allopurinol. For your low risk, it blocks new uric acid production, but it cannot clear existing uric acid that's already in the blood. If you have high uric acid in the blood, that's when you want to use rasburicase. Rasburicase dosing, it's 0.2 milligram per kilogram, but this is based on the older data. Newer data show that a fixed dose of 3 to 6 milligram for high risk, it's as effective. It actively destroys existing uric acid and works much faster than allopurinol. Electrolytes monitoring and uric acid and BNP, or like renal functions. Depending on the patient, we can monitor them every 6 to 12 hours. And in certain patients, we do want to put them on telemetry or like heart monitoring, especially if they have like high potassium or pre-existing like heart arrhythmias. And treating complications, all of these electrolyte abnormalities, they come with their own complications. I'm not going to go too much into details in treating electrolyte abnormalities, but it's no different than your other patients with electrolyte abnormalities. The big focus here is to focus on hydration. Some of the clinical pearls that we talk about in tumor lysis syndrome is that some patients you want to check G6PD before giving rasburicase. It's not always mandatory, but it is important, especially in Mediterranean men. They are at a higher risk for G6PD deficiency than other races. Patients with G6PD deficiency, and you give them rasburicase, they may develop methemoglobinemia or hemolytic anemia. Respiratory blood samples must go on ice. This is actually important and it's overlooked in many hospitals because when we draw blood from a patient that we already gave them respiratory, that enzyme, the respiratory, it's still active in the tube at room temperature. And the way to stop it from breaking down more uric acid is to put it in ice. Otherwise, you will have like falsely low results. And ideally, we would put it on ice and analyze it within 4 hours of drawing the sample. Dosing of respiratory, again, per the label or all the data, it's weight-based, 0.2 milligram per kilogram, and that could be 16 to 20 milligram of respiratory. But we know that fixed doses are just as good. And there are multiple studies that have compared 6 milligram to the weight base or 3 milligram, and it works just as good, and it's way cost effective than using weight based. And actually, at my hospital at Georgetown, we just use the 3 milligram fixed dosing, and we've had no issues with it. Allopurinol, it blocks new uric acid production, but it cannot clear existing uric acid. So if baseline uric acid is high, that's when you want to use respiratory. Previously, many providers, they used to use urine alkalinization, but it's actually not recommended anymore. It does not prevent uric acid accumulation or the kidney damage, and it may make calcium phosphate deposit worse. So we want to avoid urine alkalinization in high uric acid patients or in TLS patients. Pre-phase steroids and lymphoma can gently reduce the tumor size before full chemotherapy start. It's a useful way of lowering TLS. Sometimes we get consults on patients that, hey, there's a concern for lymphoma, we don't have a full diagnosis yet. So sometimes we just start steroids preemptively to lower the disease burden and lower the risk for TLS when we actually start treatment and have our diagnosis back. Febuxostat, that's another option that blocks xanthine oxidase, useful when albumin is not tolerated or it's not available. Our TLS case for today, it's a 28-year-old male with newly diagnosed Burkitt's lymphoma. White blood cell count is 85,000, LDH 4 times upper limit of normal. Uric acid is already at 9.1, so that's what we call spontaneous TLS. Creatinine is 1.1, baseline is 0.9, so it's not that bad, and is about to start definitive treatment with a regimen called Cordoxan. And as you're the pharmacist, you are asked to manage TLS and prevention and monitoring. And this is something actually it's driven by pharmacists at Georgetown. So we do take ownership of treating and managing TLS. First, we do need to stratify the patient, but Burkitt's lymphoma by itself is considered as a high risk, especially with the white blood cell count of 85,000. That's a pretty high risk patient for TLS, and it's most likely when we start treatment, that TLS is going to get much worse. The big main thing about treating TLS, again, it's hydration. And we want to start at 150 to 200 mLs per hour, or the recommendation actually, it's 100 ml per meter squared per hour. And we want to adjust that rate to target a urine output of 2 mLs per kilogram per hour. And sometimes patients, they get fluid overloaded or they're not urinating that much. So we supplement that with Lasix if needed. And the big thing is to know that no potassium in the fluids that you're given, so no LR in these patients. This is a patient where you want to give respiratories. Again, it's the dose. It's really institution dependent, but based on what we do at Georgetown, we use a fixed 3 milligram IV dose. If we have the luxury to check G6PD in these patients, we do. If we don't have the luxury, we just have to give it to prevent further complications from TLS. We want to monitor the electrolytes uric acid with this patient. This high-risk patient, we would monitor them every 6 hours and treat as needed. And we do want to continue or have them on continuous heart monitoring or telemetry. Things to avoid is no urine alkalinization in this patient, and we do want to monitor phosphate closely. Hyperphosphatemia, and unfortunately, that's not something we can manage with medications. If it gets out of hand, this is where you want to dialyze these patients because that's the only thing that may clear the phosphorus from the blood. And the last thing to note is high phosphorus plus or minus uric acid. That's what causes your AKI in these patients. Moving on to our third section of hypercalcemia of malignancy. So hypercalcemia is actually very common, and it's life-threatening metabolic like complication of cancer, and it occurs in about 30% of patients at this point. And if frequently actually missed or early, the symptoms can be, or the outcomes can be pretty bad. There are different mechanisms of the causes of hypercalcemia in patients with cancer. So the first one, it's PTHRP, or parathyroid hormone-related protein-mediated, and that's about 80% of the patients. And that's where the tumor produces a protein called PTH-related protein, which acts out like PTH, basically. It increases bone breakdown and causes the kidneys to hold onto calcium. So there's no release of calcium from the kidneys. And some classic tumor types that cause it, squamous cells of the lungs, head and neck, renal cell carcinoma, breast cancer is big, bladder, gynecological cancers, and some lymphomas. The other mechanism is osteolytic metastases in about 20% of patients, and this is where we have local signals of inflammatory biomarkers like IL-1, IL-6, or TNF alpha or gamma, and these directly break down the bones. And we mainly see this actually in multiple myeloma and sometimes in breast cancers when we have metastases. But in multiple myeloma, this is actually very, very common. Ectopic vitamin D, and this is like in less than 5% of the patients. So we have extrarenal production of the active form of vitamin D. And these are mainly seen in lymphomas, Hodgkin's and non-Hodgkin's lymphoma. The way to treat this is actually with steroids, because the tumor cells in lymphoma, what's driving this mechanism, and as we talked about, high doses of steroids, they have anti-lymphoma properties. So it's very good at treating this type of hypercalcemia. Ectopic PTH is very rare. I'm really not going to go over it, but I haven't seen it at Georgetown yet, but you may see it in certain patients. How do we classify these patients? It's based on their symptoms and based on the calcium levels. So if we have a corrected calcium level between 10.5 to 11.9, this is usually mild, and most of these patients have no symptoms. Moderate hypercalcemia is 12 to 13.9. That's when we start seeing some symptoms in these patients, like headaches, mostly severe or a crisis. That's when we do corrected calcium is over 14. And these patients, they come in with confusion, comas, arrhythmias, kidney failure, and this is something we see commonly, especially in multiple myeloma patients. This is the formula for corrected calcium. It's pretty easy to use, but we always want to correct for calcium, or you can get ionized calcium, which is more accurate. There are, mnemonic that we use for hypercalcemia in these patients, and that's what we call like bones, stones, groans, and psychic moans. But basically, with bones, these patients, because of the hypercalcemia, they come in with bone pain, fractures from weakened bones, abnormal areas on imaging that we see like MRIs or CT sometimes, stones, too much urination, and thirst, kidney stones and kidney injuries, groans. These are your GI symptoms like nausea, vomiting, and psychic moans. This is like the confusion, the slow thinking, the drowsiness that comes with hypercalcemia. The way we treat it, the most important thing is IV hydration. These patients are severely dehydrated from excessive urination or poor fluid intake. So we want to start at a very high rate of 200, 300 mLs per hour until they're like basically euvolemic, targeting urine output of 100 to 150 mLs per hour. IV fluids alone can lower calcium by 1 to 2 milligram per deciliter. In severe patients, we want to use calcitonin, subcutaneous, or by injection every 6 to 12 hours for severe cases. It works pretty quick, but it has tachyphylaxis. So usually it stops working about 48 to 72 hours. And that's why we want to add bisphosphonate every time we use calcitonin. And usually use zoledronic acid 4 milligram IV over 15 minutes or pamidronate 69 milligram over 2 hours. Sometimes I do like 4 to 6 hours infusion of pamidronate, especially if they have AKIs. And also it takes about 24 to 48 hours for bisphosphonate to work, and this is where the calcitonin comes in, come in handy. Denosumab, that's another drug that can be used for refractory cases or kidney failures. It's usually given subcutaneous as 120 milligram. And steroids are particularly effective in lymphoma patients and vitamin D-driven diseases. One thing to note is very important that we do not want to use loop diuretic at the start because they worsen dehydration and kidney injury. So only use or supplement these patients with loop diuretics when the patient is well hydrated. Some of the clinical pros with hypercalcemia is that we do not want to wait for the PTHRP results before treating. So act based on the corrected calcium and clinical picture of the patient. And the PTHRP results will actually not change your immediate plan. Hypercalcemia of malignancy has poor outlook, so without effective cancer treatment, historical median survival is about 30 days. So you want to make sure that you catch it and treat it. Calcitonin stops working about 48 to 72 hours because of tachyphylaxis. So don't use it by itself. You always want to pair it with a bisphosphonate. Steroids work great with lymphomas, and the dose is usually 60 milligram per day for about 3 to 5 days. Cinacalcet is FDA approved for parathyroid carcinomas and has been used in reports for other refractory cases, but it's not well used. Symptoms depend on both the calcium level and how fast it rises. Sometimes you have patients, their calcium levels as 10.5 or 11, and if you check 6 hours after, it's 14. So that rise is actually may cause more complications than if the patient presents at level of 14. And calcium will keep rising unless the underlying cancer is treated. So you want to make sure that if this is driven by cancer, then you want to treat the underlying disease. Our case example for the hypercalcemia is that we have 67-year-old woman with squamous cell lung cancer. She presented with confusion, constipation of 5 days, blood pressure is low, heart rate is at 108. Calcium is 14.8, albumin is 2.8. She has an AKI creatinine of 2.3. PTH is suppressed, and PTHRP is elevated on initial test, but the final result won't be back until like 24 hours. Should we wait for the PTHRP? Not really. That's when you will start like correcting the calcium and start treating the patient. So corrected calcium using the correct calcium formula, that it's actually 15.76. So that's severe hypercalcemia. The mechanism is PTHRP-mediated hypercalcemia from squamous cell carcinoma. So knowing what type of cancer they have, it tells you like what type of mechanism of hypercalcemia is driving this crisis. The management, you want to give aggressive fluids. You want to give calcitonin, as we talked about, for every 6 to 12 hours. And you want to pair that with bisphosphonate. Sorry. And lastly, we want to talk about hyperleukocytosis or leukostasis. So this section 4, it focuses on white blood cell count, and this is a blood vessel blockage crisis in acute leukemias. There's no single blood count number that tells you when to act. You treat patient in front of you, not the lab value, for the most part. And the spectrum of leukocytosis, hyperleukocytosis to leukostasis is pretty broad. So we have 4 different terminologies that we use, and each is different. Starting with leukocytosis, this is the definition where you have a white blood cell count over 11,000. This is usually common in like infection, inflammation, when we use steroids or stress, usually not concerning by itself, and it's reactive. Hyperleukocytosis is different. This is when we have a white blood cell count over 100,000. In AML, the definition is a little bit different. It's when we have white blood cell count over 50,000 because the myeloblasts are large and stickier than other lymphocytes. And they block small blood vessels much more effectively at a lower count. So that's why the definition is a little bit different. Blast crisis is different. This is not based on the white blood cell count. It's actually based on the blast count, which is different than a white blood cell count. And it's defined by 20% in the periphery in AML or 30% in chronic myeloid leukemia. And that changes into a more aggressive disease. So again, the diagnosis is based on the blast percentage, not the white blood cell count alone. Leukostasis, this is a clinical syndrome. So symptomatic blockage of small blood vessels in the lungs, brain, or both. Sometimes you see in the kidney, sometimes the liver. And there's no fixed white blood cell count number to this diagnosis, but usually these patients, they would come with these complications with the white blood cell count is usually around 150 to 100,000. And if you have a patient like with a white blood cell count of 80,000 and active breathing failure, has leukostasis and needs immediate treatment. So we want to treat the symptoms, not the number. A little bit about the pathophysiology. So the leukostasis mechanism has 5 steps. So large, rigid blast cells, especially in AML subtypes of like what we call M4 and M5, these are sticky blasts. So they stick to the blood vessels and they cause like a cytokine release activation. They block small blood vessels, and once stuck, the blast activity consumes local oxygen. The result is oxygen deprivation or hypoxia in the brain, lungs, kidney, and heart, and that's what causes the failure of these organs. This is actually made worse by 2 major problems happening at the same time. If you have a TLS patient, or like because they have like high burden of disease, if you have DIC, especially in APL patients, procoagulant release causes low fibrinogen and a prolonged clotting time. And there are important lab artifacts you must know in these patients who have high white blood cell count. These patients present with pseudo hyperkalemia. So the numbers that you're reading on the screen, sometimes it's not accurate, it's not representative. Pseudo hypoglycemia and pseudo hypoxemia. So you really want to make sure that you are assessing the patient that you have and not just the numbers that you have on the screen based on the labs. The clinical manifestations, so leukostasis show up mainly in 2 ways, pulmonary and CNS most of the times, but it can present in the kidneys, the liver as well. Pulmonary leukostasis, these are your patients with high white blood cell count and shortness of breath, low oxygen, and widespread bilateral changes on the chest. CNS locostasis, this is your headache, confusion, vision changes, and neurological deficit. Coagulopathy does not help, and this mainly we see it in patients with acute promyelocytic leukemia. Again, other manifestations that we see, renal failures, priapism, retinal hemorrhages. And the workup is pretty straightforward. That's when you're going to get to CBC and assess your patient as appropriate. Patients who present with leukostasis, about 15-20% of AML patients present with hyperleukocytosis when first diagnosed, and early death is about up to 20% when the white blood cell count exceeds 200,000. So it's very important to act quickly in these patients. And the way we treat it is with first supportive care. And that's when you want to give them aggressive IV hydrations. You want to make sure that to prevent TLS if there's no TLS, or treated and use rasparequis in these high patients. And what I usually do with rasparequis is give them a prophylactic dose of 1.5 milligram, and that works well when treating that white blood cell count at that number. A big thing is that we want to avoid red blood cell transfusion if possible, especially when the white blood cell count over 100,000, because it thickens the blood and worsens vessel blockage. But that's not something that stops us from giving blood transfusions, especially if patients come in with anemia like hemoglobin of 6 or 5. So these patients, you still want to transfuse them, but you want to be very careful at monitoring them. Platelet transfusion if they have thrombocytopenia to reduce mainly brain bleeding risk. And ICU admission if they have symptomatic leukostasis. Cytoreduction is huge. The first thing that we want to give is hydroxyurea. Usually the dose 50 to 100 milligram per kilogram per day, but we usually divide it into 2 to 3 doses throughout the day just because of the half-life. And patients who actually have leukostasis, I do use low-dose cytarabine, usually as 500 milligram, and I like to infuse it over 24 hours to reduce the risk of PLS. And it works very great in these patients. Steroids works great again in lymphoma patients and in your ALL patients. One group that we're not going to go into too much details are your acute promyelocytic leukemia patients. They do present with high white blood cell count, and this group of patients, they cause different complications like DIC, and these are the patients that we want to start all transuranic acid plus or minus arsenic. This is a different discussion for a different day. But the main idea is that we want to start definitive induction chemotherapy for these patients to stabilize them. Some of the clinical protocols to talk about in hyperleukocytosis is leukocytosis is a clinical diagnosis, it's not based on the white blood cell count. The SpO2 may be falsely normal. This is, again, you want to pay close attention to it. This is a controversial topic between providers. Pseudohyperkalemia, hypoglycemia, and pseudohypoxemia are real. So be careful of the numbers that you're looking at on your screen. In APL patients, you want to start ATRA or all-trans retinoic acid immediately, and we want to use the hydria to lower the blood count. In patients who have blood cell count over 100,000, if you can avoid red blood cells, we should avoid it. Otherwise, if your patient have severe symptoms from the anemia, then you want to transfuse them. Big thing to note is that leukapheresis, this is something historic and have been used quite often in the past. It's not recommended anymore because there's no long-term survival benefit. And that's not something we use no matter how the white blood cell count is. And again, with the use of hydria and cytarabine, we do a great job at reducing the white blood cell count. The last case example is a 32-year-old man coming in with fatigue. bleeding from his gums and worsening shortness of breath. Vital sign count was 185,000 with 90% blast. Hemoglobin is 7.2. Platelets is 18,000. Fibrinogen is 80. PT is prolonged and peripheral blood smears show large blasts with hour rods. SpO2 94 on room air, and blood pressure is soft at 106/72. So looking at that fibrinogen as the prolonged PT, this is your patient, how we diagnose what we call acute promyelocytic leukemia. So this is the patient before giving anything, we want to give them Atra as quick as possible to prevent the IC or bleed in the brain, or bleed just in the body, anywhere actually. And in these patients, we use like Hydrea as well, and sometimes cytarabine, depending on the clinical scenario. And if your patient has actually APL, you want to target the platelets over 50,000 and fibrinogen over 150. So that's when you want to give them like precipitates to increase that fibrinogen. Apheresis, it's not recommended at all, especially in APL patients or patients with DIC. It actually worsens it. The SpO2, it may be falsely normal, but it's not. It depends on the patient's symptoms. Cytoreduction we talked about. We want to start definitive treatment with Atra and plus arsenic, and sometimes we supplement that with Hydrea and cytarabine if needed. The key takeaways are with febrile neutropenia is that you want to start antibiotics within 60 minutes, and you want to make sure that you have anti-pseudomonal beta-lactam monotherapy, or plus or minus vancomycin, depending on the patient presentation. Tumor lysis syndrome, you want to hydrate aggressively, and you want to use respiratory in high-risk patients. Hypercalcemia, you always want to correct calcium for albumin, or you can get iCal, and you always want to start with hydration as well. Hyperleukocytosis, it's a clinical diagnosis, not always rely on the numbers. And APL patients, you want to start Atra as soon as possible. The unifying message here is early recognition and fast action actually saves lives, and pharmacists who know these algorithms, who anticipates flags and start treatment before being asked, is one who actually makes a real difference in these patients. These are some of my references attached into the presentation, and now I can take any questions. I think we're just hitting the right time at 9:30.
Humam, I have a question.
Yeah.
When you give respiratory for tumor lysis syndrome, what's the duration of action for that? And are there times when you might consider repeating a dose or giving a second dose?
Yeah, definitely. So when we use respiratory, we see immediate action to it. Within 4 to 6 hours, it starts working. The big thing about it is that you want to give respiratory with fluids. If your patient is not urinating or making a good urine output, that uric acid is not going to clear. So you want to make sure they're hydrated, they're on aggressive fluids, and you give them respiratory. And in high-risk patients or patients with, coming in with uric acid of like 10, 12, or 13, I give respiratory and I give Lasix about 2 to 3 hours after with the fluids to make sure that they're clearing that uric acid, and it also helps with other electrolytes. Repeating the dose. So we know that repeating the doses less than 24 hours is not going to be that effective because it's still acting in the body for up to 24 hours. So I usually wait 24 hours before repeating that dose again. Again, you want to make sure that your patient is on aggressive fluids. And passing 2 doses or sometimes 3 doses is not going to be effective. So more than 2 to 3 days of respiratory is not going to be more effective. And your TLS management should happen within the first 24 hours. So you should be having that TLS under control, ideally within 24 hours.
Okay, thank you.
You're
My other question is that in those patients who have really high phosphate levels, would it be helpful to give them an oral phosphate binder, or will it make any difference?
So the phosphate binders, they bind the phosphorus in the guts, but it's not extracting any phosphorus from the plasma or the blood. And that's why we give these phosphates with food. So it only binds the phosphorus that comes from supplemental food. But it's not going to clear existing phosphorus in the blood. And that's why if it gets too high, that's where dialysis come in place. And again, that's why aggressive fluids and targeting a good urine output is important, because these are the only two ways to clear plasma phosphorus.
Any questions from attendees? Okay, we have a question in the chat. It says, in the leukemic patients with leukocytosis, what is the best route of administration of sodium bicarb, and which tests, serum or urine pH, are best to check?
So why do we want to give them sodium bicarb to patients with acute leukemias? Usually sodium bicarb is not given in these patients. If you mean like for high uric acid, this is not recommended. But sometimes we give them sodium bicarb in patients who are on like medications like high dose methotrexate, but this is given sodium bicarb to a patient with hyperleukocytosis, it's not applicable. I don't see a role for using sodium bicarb in these patients. Maybe I'm misunderstanding the question. Any other clarifications or?
Okay. So there's confirmation that you understood the question well. So thank you for your response, Humam.
Okay.
So I want to just make a note that the slides, the link is available in the chat, so you can download the slides. And also in the chat, there's a link to the YouTube recordings for all the ICU lectures. So you can listen, to the recordings for all the ICU presentations. And this is the presentation provided by SAMS Pharmacy Assembly, قسم الصيدلة بSAMS. And we will have more presentations coming up in the summer and also the fall. So stay tuned, and we hope that you join us in future presentations. We have another question in the chat. It says, in patients who are diagnosed with squamous cell carcinoma, non-squamous cell lung cancer, and do not have hypercalcemia, is there any need to initiate with bisphosphonates as a prophylaxis?
Not in lung cancers unless they have metastases to the bones. So sometimes these patients present with metastatic disease to the bones without hypercalcemia. So these patients, you do want to give them monthly doses of bisphosphonates or denosumab. Unlike patients with multiple myeloma, regardless if they have normal calcium or high calcium, and if they have metastatic disease, like bone lesions or not, these patients always get bisphosphonates. So it really depends on the disease that you're treating. But in squamous cell lung carcinoma, if they don't have bone metastases, then there's no role for bisphosphonates.
Okay, and the link for the slides is at the top of the chat. So you see the first link is the link for the slides in the top of the chat. Okay. Thank you so much, Dr. Humam Alkhaled. Thank you so much for the presentation. And we look forward for you to join us in future presentations.
شكرا للكل.